Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to discuss about prolapse. So prolapse is one such important topic without which you can't attend any examination, right? When gynae is concerned, there are some particular important topics without which you can't just attend any examination. So one such important topic is this prolapse. So what do you mean by prolapse? So prolapse is displacement of organs from its normal anatomical position. See, in our body, every particular organ has its own anatomical position. The heart is situated in the pericardial cavity. The lungs are situated in the pleural cavity or the thoracic cavity, right? And the uterus is situated in the pelvic cavity. Similarly, all these organs are held in its normal anatomical position with the help of some supports. These supports could be any sort of mechanical support, muscular support and ligamental support as we discussed in the previous module. If in case all these supports of the particular organ is going to get weakened, so because of weakening of these supports which is supporting the organ might get displaced from its normal anatomical position due to lack of the support. Because of weakening of all these muscular and ligamental supports, these organs can get displaced from its normal anatomical position. So this is termed as prolapse. And as far as gynae is concerned, we have two important prolapse, that is the uterocervical prolapse and the vaginal prolapse. So uterocervical prolapse will be taken into consideration in this module. Right. So I told you that prolapse is basically because of weakening of the supports of the particular organ. So because of the weakening of the supports, the organ is getting displaced from its normal anatomical position. Right. So here we are going to discuss about the uterocervical prolapse. So before discussing about uterocervical prolapse, let's take into consideration what are the risk factors. So risk factors for prolapse are elderly menopausal females. See, menopause is more common in females around the age of 47 to 51 years, which is the ideal age group for attainment of menopause. So all elderly menopausal females are at risk of prolapse. And any female who has had history of birth trauma, let's say for example during vaginal delivery, a female has received an episiotomy. Episiotomy is when you give by yourself a knit so that the fetus is going to be delivered properly without in itself causing any perineal tear. So iatrogenically, I'm going to give a net hand mediolaterally and I'm going to deliver the fetus. If by chance, if this net is going to be extended beyond its own limit, if it is going to extend inside the perineum, it might cause perineal tear. Right? So perineal tear can either be caused because of the delivery of the fetus, because of this obstructed and prolonged labor, which might result in this perineal tear, or it might be caused iatrogenically when a clinician is going to make a knit as an episiotomy mediolaterally, and if this knit is going to be extended further, it might involve the vaginal mucosa, the muscles and the anal sphincter. So any sort of birth trauma because of some obstructed labor, prolonged labor, where the fetal head is going to be obstructed in the introitus, vaginal introitus, where in itself it might lead to some sort of perineal tear. So because of this perineal tear, the perineal muscles will get weakened. So because of this weakening, since the female had a history of birth trauma in her past, later in life, after she attained menopause, during her elderly period, she might be at high risk for this prolapse because of weakening of this perineal structures. Clear? Yes. Followed by multigravida female. Who is a multigravida female? Any female who has given birth to more than equal to 2 live births. Right? So this female has been pregnant for more than once. She has been pregnant for 2 times or sometimes even more than 2 times. Right? So every time when the female is going to pregnant, she is going to deliver. So if she is having some sort of vaginal delivery or C-sections, anything, this might lead to weakening of these structures because the uterus is going to be distended when she is pregnant and slowly it is going to involute, and this might result in weakening of the muscular and the ligamental supports of the uterus, right? And this might result in weakening of all these supports which might present in later life as prolapse. So multigravida female, history of birth trauma, menopausal, elderly menopausal female are at risk of prolapse. And apart from that, as I told you earlier, history of obstructed labor, prolonged labor, because obstructed labor in itself will lead to perineal tear. prolonged labor, history of any instrumental delivery such as the forceps delivery, vacuum assisted delivery, any sort of instrumental delivery, and if the female is an obese female, chronic smoking is going to increase the intra-abdominal pressure, such as chronic cough in patients of COPD who is going to present with chronic cough, chronic constipation, any sort of intra-abdominal tumor, where there is going to be increase in intra-abdominal pressure. So this increase in intra-abdominal pressure might result in prolapse of the uterus. And any female with history of connective tissue disorder such as the Ehlers-Danlos syndrome and Marfan syndrome, where the tissue support is going to be very weakened. So because of weakening of these tissues, where there could be prolapse of the uterus and the cervix. Is that clear for you? See, the risk factors for uterocervical prolapse is elderly menopausal female, history of birth trauma, multigravida female, history of obstructed labor, prolonged labor, instrumental delivery, obese female, increased intra-abdominal pressure, chronic smoking, chronic cough, chronic constipation, intra-abdominal tumors, any history of connective tissue disorders in the family. All these factors are just linked to only one thing, and that is the weakening of the supports of uterus, weakening of the perineal muscles, right? Weakening of the perineum. All these are going to result in the prolapse of the uterocervix. So basically, everything is just aimed at one, and that is weakening of the supports of uterus. And this support could be either the muscular support, ligamental support, perineal muscles, perineum, and anything, right? Good. And as you can see here, this is the normal position of the uterus. So this is the bladder, this is the uterus, and this is the rectum. This part is the cervical part and this part is the vaginal part. So I'm going to define it as prolapse when the uterus along with the cervix is going to descend further down inside the vagina. Sometimes it will be inside the vagina, and sometimes it will be at the level of introitus, and sometimes it will descend all outside, where the entire uterus along with the cervix is going to be coming outside the vagina, where it will be visible for the naked eye. Clear? Yes. So now we have a classification for this uterocervical prolapse. See, it is very clear. Let me give a gist for you. Uterocervical prolapse is when the uterus is getting displaced from its normal anatomical position, and the risk factors are those which are directly linked to weakening of the supports of the uterus. Elderly menopausal female, history of more than equal to 2 live births. Because the female has been pregnant for more than 2 times, this might result in the weakening of supports of the uterus. Muscular ligamental supports of the uterus might get weakened. History of chronic cough, chronic constipation, intra-abdominal pressure, because anything which is going to increase the intra-abdominal pressure will result in prolapse of the uterus. And apart from that, any family history of connective tissue disorders, Ehlers-Danlos syndrome, Marfan syndrome, where because of the connective tissue disorder, genetically, the patient might be having weakened supports of the uterus, the ligaments and the muscular and the perineal floor muscles will be weakened in this patient. So uterocervical prolapse can be anticipated in those groups of patients, right? So the risk factors of prolapse are very clear now. Now we are moving to the classification of uterocervical prolapse, which is termed as the Shaw classification, right? So in Shaw classification, we have first degree, second degree, third degree, and procedentia. So this is the normal uterus. As you can see here, this is the normal position of the uterus. So in the first degree is when the uterus along with the cervix descend in the vagina. So you can see the uterus and the cervix in the vagina. So in the vagina, the uterus and cervix is present. So descent of the cervix in the vagina is first degree uterocervical prolapse. Second degree is when the descent of the cervix into the introitus. So introitus is the vaginal introitus, right? So in the introitus, the uterocervix has descended. So the uterus along with the cervix is descended into the introitus. So it is at the level of the introitus, as you can see here. Here it is into the vagina. Here it is at the level of the introitus, and in the third degree, it is outside the introitus. Outside the introitus itself, you can visualize the uterocervix. And procedentia is when all of the uterus along with the cervix is outside the introitus. The third degree is when the uterocervix is visible outside the introitus. But procedentia is when all of the uterus along with the cervix is outside the introitus. Whole of the uterus and the cervix is outside the introitus. That is called as procedentia. See, the first degree is when the uterocervix is into the vagina. Second degree is when it is at the level of the introitus. Uterocervix is at the level of the introitus. Third degree is when it is outside the introitus, and procedentia is when all of the uterus along with the cervix is visible outside the introitus. So completely you can visualize the uterus along with the cervix outside the vaginal introitus. So this is the Shaw classification of prolapse, which is a very important classification. The other classification we have here is POPQ classification. What is POPQ classification? So POPQ classification was recently asked in the previous 2024 NEET PG examination, where this image was given and the question was, in this group of classification is used for classifying which condition. So the answer was what? The answer was prolapse, right? So POPQ classification is when pelvic organ prolapse quantification system. So POPQ classification grid has been given here. You need not know any details about this POPQ classification because that has not been asked anywhere. But then you need to know what is POPQ classification. And in this POPQ classification, they have taken a reference point considering which this classification is already done. So the reference here is the hymen. So hymen is the reference point in POPQ classification. So keeping hymen as the reference point, they have classified this prolapse. So in future, if you get this kind of grid in any examination, just remember that this is POPQ classification grid where the reference point is hymen. This is just enough for you to know. Okay, so now moving to the symptoms of uterine prolapse. What are the symptoms of uterine prolapse? See, we are not taking into consideration the vaginal prolapse now. We are discussing only about the uterine prolapse. So everything which is related to uterine prolapse will be discussed now. So when we discuss about the uterine prolapse, the patient will come to you with complaints of feeling of something is coming outside the vagina. The female, the elderly menopausal female will come to you with complaints of that, doctor, I feel something is coming outside of my vagina. Or she might complain you that a mass is descending through her vagina. See, the symptoms could be two things. She might tell that feeling of something which is coming outside of her vagina, or she might come to you with that a mass is descending in my vagina. I can see a mass outside my vagina. Or she might tell you that I can feel that something is coming outside her vagina. The second thing is that because of the mass is descending per vagina, the female might have some discomfort while walking. Right, because the mass is outside the introitus, so definitely the patient will feel some discomfort while walking, and the patient might also complain of low back ache. The low back ache is basically because of the mid-sacral strain. Mid-sacral strain. So because of the mid-sacral strain, the patient might complain of low back ache, and apart from that, the patient might also complain of dyspareunia. What is dyspareunia? Dyspareunia is painful intercourse, and apart from that, the patient might have feeling of pelvic pressure or pressure is in the vagina. Where you can see pressure in the vagina? See, I told you in the, as you can see here, right? Let me show you here. In the first degree, the descent of the uterocervix is in the vagina. Since it is in the vagina, the patient might feel some sort of pressure in the vagina because the uterus and cervix is descending into the vagina. So the patient might complain of pressure in the vagina or feeling of pelvic pressure as well. And the patient might also have some complaints such as white discharge per vaginum as well. And the patient is telling you that, doctor, that every time I just need to reduce the mass manually inside, only then it is going to be okay for me, or else the mass is going to be descending outside my vagina. So every time the patient needs to reduce the mass manually, right? So all these could be the symptoms with which the patient can present to you, right? So this is all about the symptom a patient will come to you regarding prolapse. Good. Now we are moving to the examination. So when taking into consideration the examination, we need to examine for pelvic organ prolapse in various positions. We need to ask the patient to be standing position. You have to examine for prolapse. You need to ask the patient to do a particular maneuver which is called as Valsalva maneuver, where you basically need to ask the patient to cough or strain. So only when the patient is going to cough or strain, you may be able to demonstrate prolapse in the early degrees of prolapse. Let's say, for example, first or the second degree prolapse, only when the patient is going to cough or increase the abdominal pressure or strain, like when she is going to pass her stools, we will be able to demonstrate the prolapse. So you need to examine the patient in standing position, in squatting position, and in the lithotomy position. So in all these three positions, you need to examine the patient, right? And now I have a very important question to you. See, it is asked in many frequent MCQs wherever I have gone through. What is the difference between this uterine inversion and uterine prolapse? Uterine prolapse is gynae. Uterine inversion is obstetrics. Clear? Uterine inversion is obstetrics. Uterine prolapse is gynae. Uterine inversion is when, because of the retained placental tissue, where there could be postpartum hemorrhage, during the postpartum period, we can expect this complication of uterine inversion, where the fundus of the uterus is going to be inverted upside down. As you can see in this image, this is the fundus of the uterus. Ideally, the fundus should be here, right? The fundus should be here. But because of this uterine inversion, what is going to happen is the fundus of the uterus is going to turn upside down. So the fundus is upside down now. So this fundus of the uterus is outside the vagina. So it is inverted. So the uterus is basically inverted. And the most probable reason for this uterine inversion is some retained placental tissues, which will result in postpartum hemorrhage. So uterine inversion is a complication which occurs during the postpartum period, where the fundus of the uterus is going to be inverted and it is going to be visible outside the vagina. So if you're going to examine the patient, right, if you're going to examine the patient, you're going to see some mass descending per vagina. So you need to, as a clinician, you need to be vigilant enough in order to differentiate between uterine inversion and uterine prolapse, which is very basic, right? So uterine inversion is when the fundus of the uterus is outside the vagina. But uterine prolapse is when uterocervix, where the cervix is outside the vagina. Is that clear? As you can see here, right, this is the cervical portion of the uterus, whereas this is the fundus portion of the uterus. Here you can visible the os, right? The os is visible here, but then here there is no os is visible for you. So if the fundus of the uterus is outside the vagina, it is called as uterine inversion. But if you are able to see the os, when you see the examination, when you examine the vagina of the female, if there is a mass descending per vaginum, you need to differentiate the mass. If in the mass there is an os situated, it is uterine prolapse. If there is no os, it is the fundus of the uterus which is seen in uterine inversion. So if the os is visible, it is uterine prolapse. If the fundus is visible outside the vagina, it is uterine inversion. Is that clear? Yes. Now, during examination, as you see, while doing the examination, you examine the patient in lithotomy, standing and in squatting position. But when you are going to visualize this prolapse part outside the vagina, you might be able to see some ulceration in the prolapse part, which is basically called as decubitus ulcer, So decubitus ulcer is nothing but this ulcer is happening due to venous congestion. All the blood is going to get stagnant in the veins itself. So because of venous congestion, or due to friction, or because of circulatory changes in the dependent part of the prolapse tissue is getting ulcerated due to tissue anoxia. See, venous congestion is when all of the blood is going to get stagnant in the veins itself. So because of this venous congestion, due to lack of oxygen, the tissue is going to undergo tissue anoxia. So tissue anoxia is going to result in ulceration of the prolapse dependent part. So this ulceration is called as the decubitus ulcer. And this decubitus ulcer can rarely undergo malignant transformation. Is that clear? These decubitus ulcers can rarely undergo malignant transformation. And this, when you visualize this decubitus ulcer, right, you always need to take some biopsy from this ulcer and send it for histopathological examination. And when you send it for HPE examination, this ulcer has clean edges. The edges of these ulcers are clean. Is that clear? So as you can see here, this is the decubitus ulcer. So this is the prolapsed part which you are able to visualize outside the vagina. And here you can see some ulceration. And this ulceration is nothing but the decubitus ulcer, which happens basically due to venous congestion, which resulted in tissue anoxia causing ulceration of the prolapsed part of the uterus. Now, what is the management of this decubitus ulcer? See, this decubitus ulcer has to be managed by packing. You have to pack. So this packing has to be done with an antiseptic agent and a hygroscopic agent. So antiseptic agent is basically to prevent any sort of infection, and along with that you need to use an hygroscopic agent. Because of the venous stasis, there could be accumulation of excess amount of fluid which is called as edema. So in order to reduce that, you need to administer hygroscopic agent along with antiseptic agent in the vaginal pack, and you need to do vaginal packing. So the antiseptic which you are going to use here is the acreflavin, and the hygroscopic agent which you are going to use here is the glycerin. Now you might have a doubt that why acreflavin is used as an antiseptic in here instead of betadine, which is used very commonly in every setting. It is because of the fact that I told you that from the decubitus ulcer you need to take biopsy and send it for histopathological examination every time. If you are going to stain the prolapsed part, the decubitus ulcer, with betadine, then you will not be able to visualize which is the normal and which is the abnormal area. So when you're not able to differentiate between the abnormal and the normal area, then you won't be very appropriate in taking the biopsy from the decubitus ulcer, and therefore the reports will not be satisfactory, right? So for that reason, in order to avoid staining of the decubitus ulcer and the prolapsed part, you need to use acreflavin as the antiseptic instead of betadine. Is that clear? Yes. And when you do the examination in this patient, you also need to check the BMI of the patient, because in obese female it is more common, right? And you also need to evaluate history of any COPD in this patient, history of constipation in this patient, any family history of connective tissue disorders, any myopathies which is running in the family as well. So until now we have discussed the most important salient points with respect to uterine prolapse. We discussed about what is the definition, what are the risk factors, what are the degrees of prolapse, what are the classification systems which are available for uterine prolapse, and what are the symptoms with which the patient will present to you, and how are you going to supposed to do the examination, and what are the features which you will be able to see while examining what is decubitus ulcer, how you will manage decubitus ulcer, and what is the difference between uterine inversion and uterine prolapse on examination. So in the next module, we'll be dealing about how to manage a case of uterocervical prolapse. And in the subsequent modules, we'll be discussing about the vaginal prolapse as well. So I hope this topic is very easy for you to remember. So in case if you have any doubt, please just write to me in the Mackler Gmail handle. I will reach out to you as early as possible. Right? And please subscribe to the Mackler